Thank you so much. I would like to start by thanking you, Martha. This conference has advanced the field. So I want to say thank you to Martha and all of the folks at the ISF. It has not been a small thing. And I also thank you to RWJF and all of the folks who have supported this conference, the folks at Scattergood. This is huge. It needed to happen. I want to personally say thank you to all of our supporters at the Center for Youth Wellness, which include the Tipping Point community, Attorney General of California Kamala Harris, the John and Lisa Pritzker Family Fund, the 49ers Foundation, the Sarlo Foundation, and the California Endowment. And I also would be remiss if I did not say a huge thank you to the support for the support of my team at the Center for Youth Wellness and the Bayview Child Health Center. Here is the clicker. So when Martha and I talked, we said the initial title of my talk, or the title we agreed on, was ACEs, Why Every Clinician Should Care. And as I started preparing my comments, I realized that I was going to change my title to Why Every Pediatrician or Why Every Clinician Shouldn't Have to Care, right? Which is essentially why this should be standard of practice. And it shouldn't require the personal passion of individuals for us to begin to do universal ACEs-informed care. Now, I love coming to this conference and been speaking because I don't have to go through the ACEs data. Usually, when I give my talk, I start talking about my experience as the founder of the CPMC Bayview Child Health Center and what happened when I learned about ACEs and how that transformed my practice, understanding the clinical impact of ACEs on the health of my patients. And I'll just, briefly go through and say, when I look at exposure to ACEs, for kids who have 5 or more ACEs, twice as likely to develop headaches. For 4 or more ACEs, 2.5 times as likely to develop COPD. For 6 or more ACEs, 3 times as likely to develop lung cancer. For 4 or more ACEs, 2.5 times as likely to develop liver disease. For ischemic heart disease, the relative risk 360% for ACEs greater than 7. Ischemic heart disease being the #1 killer in the United States of America. For autoimmune disease, 70% increased risk of Th1, T helper cell 1 disease, 80% increased risk of T helper cell 2 disease, 100% increased risk for rheumatic disease. So we see that there are multi-systemic impacts, and these impacts are neurologic, specifically impacts on the HPA axis, the dysregulation of the hypothalamic pituitary adrenal axis, dysregulation of the ventral tegmental area of the nucleus accumbens, which is we know is the reward and addiction center of the brain, hippocampal neurotoxicity, neurotransmitter and regulation and receptor dysregulation, effect on our immune system with increased inflammatory mediators and markers of inflammation such as interleukins, TNF-alpha, and interferon gamma. And when we look at this particular data is from the Nadine study looking at markers of inflammation, and they specifically looked at high sensitivity CRP, fibrinogen, and white blood count for no probable and definite childhood maltreatment, and they found a direct correlation between childhood maltreatment and inflammatory mediators. Now, mark you, unlike the ACEs study, which was a retrospective study, this was a prospective study where they followed all the kids who were born in Dunedin, New Zealand, and followed them out prospectively. So we see over and over again these multi-systemic impacts. Impacts on your endocrine system with dysregulation of adult ACTH and plasma cortisol levels, and that these impacts are not just impacts in a moment in time, but we see that maltreated children with PTSD were found to excrete higher urinary cortisol and adrenaline breakdown products years after disclosure of abuse. So we see this is all the stuff that we've been hearing about, which are the long-term changes to your neurologic, immunologic, and endocrine systems. And we heard from Dr. Garner that the way that this is mediated is through epigenetic regulation, changes in the way that our DNA is read, transcribed, and expressed. Now, you'll notice in here that I didn't mention in my multisystemic impacts any mental health or behavioral impacts. And the reason is because we already know that, and that the mental health and behavioral health systems are already on board, right? So let me say this. When I go to speak, I speak with huge rooms full of people who are dealing with mental and behavioral health because it's already their problem. What I'm trying to do is I am trying to convince every pediatrician in the United States that it's their problem. And so, what is the role of clinicians in transforming clinical practice? And I'm speaking specifically about pediatricians. If you look at the AAP website, right, the Center on, this is too tiny, the Center on Workforce and Medical Education Policy, in the most recent data that they have, which was from 2009, we understand that we have 58,194 general pediatricians, 4,322 med-peds trained pediatricians, and 19,091 peds specialists. And how do we get 85,000 pediatricians to begin practicing ACEs-informed care? Well, when we look at the curve of diffusion of innovation, right, I'm trying to figure out how the heck do we get to 100%? And the reason I say the name of my talk is why every clinician shouldn't have to care is because in order to get to 100%, we can't just appeal on people's sensibilities. We can't get everyone to take this on as their own personal crusade. We have to figure out a way to make this standard of practice. My mom doesn't use the internet, right? She doesn't know how to use Google. We bought her an iPhone, and she uses it to dial, but she doesn't know how to text, and she doesn't know how to use any of the functionality. My mother is a laggard, okay? And it's not because she doesn't believe in the internet, and it's not because she has something against the internet. It's because she's afraid of technology. And when it comes to technological things, she's also kind of lazy, right? She doesn't want to learn. And so my question is, how do we get folks like my mother, right? So how do we get clinicians? Because there are going to be some clinicians who are the folks that buy the $600 iPhone. They're the first ones in line. They're in line outside the Apple store, right? And they want to be the first ones to transform practice. That is the folks who are in this room today. And then there are the folks who are like my mom, right? Who have to be, essentially what needs to happen is that the old form of practice needs to be so outdated that they essentially don't have access to it anymore. If my mom could get her hands on a rotary phone, she would, I promise you. Right? So how do we transform practice? Well, certainly it requires a public health approach. So that requires a public awareness campaign, public policy intervention, systems change, and I'm going to credit my buddy Andy Garner, who I now have like a kind of a work crush on. I'm going to have to go home and admit that to my husband. But for this piece, we have to align the educational, financial, logistic, administrative, and system support for basic science and translational research for the development of evidence-based practices, and for training of clinicians and researchers to develop and implement effective interventions. We need a public health approach. But we also need credible clinical intervention. And that means that we need a clinical screening tool that is brief and actionable. I am not talking about an enhanced history-taking tool. I'm talking about something that we are all responsible for. When a patient comes into my clinic and their temperature is greater than 100.4, I, as a pediatrician, am responsible for that temperature. I'm responsible for responding to that fever. When I get a white count and I have a reference range, if it's out of range, I'm responsible for responding to it or documenting why I didn't respond to it. We need a straightforward clinical algorithm to tell all these folks, because we can't ask those 80,000 pediatricians to each figure out what is the right thing for them. They need a simple, straightforward clinical algorithm that they can employ. And I believe that we need to track biomarkers. The reason this may be a little controversial, the reason I believe that we need to track biomarkers is for several reasons. One is because it fits into the theoretical framework of what pediatricians believe that they do, right? That's a sad thing to say. But many pediatricians feel like, hey, if I can't measure it, then otherwise I'm just counseling. When we give folks something to hold on to, BMI, you measure the BMI is high, your job is to bring that BMI down, right? If I have a kid and their BMI is greater than the 95th percentile, if that kid is 5 years old, I gotta put a needle in their arm and check their cholesterol level. Now, let me ask you something. For my average 5-year-old patient, which is a greater predictor of their clinical outcome? That cholesterol level or their ACE score? What percentage of my clinical colleagues do an ACE score on every single one of my kids, on every single one of their patients? What percentage of my colleagues will put a needle in that kid's arm and check their cholesterol level? All of them do. And if they don't, they're a bad doctor. Right? And I don't like to cast judgment on people, but we need to have a standard of practice. Some people are motivated by doing the right thing. Some people are motivated by holding on to their medical license, right? But whatever it takes, we need to figure out how to get that curve to 100%. Now, at the Bayview Child Health Center, we developed our clinical protocol, which is that we screen every child for adverse childhood experiences. If their score is 0, great. If it's 1 to 3 and no symptoms, we do anticipatory guidance. If it's 1 to 3 with symptoms, we refer to our multidisciplinary rounds, which is our system which includes clinicians, mental health specialists, and case managers. And if their ACE score is 4 or more, we refer to multidisciplinary rounds. And the other purpose of doing this ACE screen, and for having a way to stratify an ACE score, is for allocation of resources. Allocation of resources in terms of my clinical time. It's allocation of resources in terms of our health dollars, allocation of resources in terms of referral to specialists, all of these things. If I have a kid and they're asthmatic and I follow the NHLBI guidelines, the National Heart, Lung, Blood Institute guidelines, that tells me that I should bring them back every 6 months to follow their asthma. If they have an ACE score of 6, I am going to allocate my clinical resources differently. I'm going to bring them back more frequently because I know that that family is going to have a more difficult time. There are more barriers to intervention. And immunologically, this child is at a higher risk of having greater chronic inflammation within their system. So I'm looking at biological, public health, resources oriented. I'm thinking about how we are allocating our resources. And that is why we screen. This is not an enhanced social history-taking tool where I get to say, God, that's awful. I give you a hug. We hug it out. I go on to my next patient and I don't change my practice, right? So the next thing that we do also is teaching clinicians how to assess for symptoms. Because again, that fits within our clinical, our paradigm, our framework. Doctors feel like when there's a problem, they gotta assess for some symptoms. And guess what? There are symptoms, including sleep disturbance, weight gain or loss, enuresis or onchopresis, hair loss, developmental regression, school failure or absenteeism, failure to thrive, poor control of chronic disease, aggression, disordered attachment, poor impulse control, restricted range of affect or numbing, and high-risk behavior in adolescence. All of those are symptoms that every clinician should know is going to put, is a red flag for ACEs. And if you haven't done your ACE screen before, you should certainly do it when you're seeing this constellation of symptoms. So when we look at, So at the Center for Youth Wellness, we're developing a series of training curricula, and one of them is our ACEs curriculum for providers. And when we do this ACEs curriculum providers, so step 1 is introduction to ACEs, which is why you should care. Step 2 is homework, developing a database of community resources and high quality referrals. The reason for that is that age-old question: how do you screen if you don't have resources? How do you, is it ethical to screen if you don't have anything to do, right? So the clinical homework, step 2, is before we teach people how to screen, we say, gather your resources and you better know what you're gonna do with a positive screen. So find out where all of your community resources are, find out who you can refer to. And then step 3 is the clinical screening. Step 4 is follow-up, troubleshooting, and CQI, which is continual quality improvement. And let me tell you, when we opened the Bayview Child Health Center with a focus on reducing health disparities, we had some amazing outcomes. And I'm going to show you, this is something I presented to our CEO in 2010. This is the asthma hospitalization rate for our community citywide in San Francisco. We have in the Bayview Hunters Point neighborhood the highest asthma hospitalization rate in the city of San Francisco. And then we have the Bayview Child Health Center, lower than the citywide average. For our immunization rate, we had the citywide average for immunization. We had the citywide average for Bayview, which was lower than the citywide average in general. Sorry, so we had the Bayview average immunization rate. And then we even looked at what were our own patients before they came to the Bayview Child Health Center. So we went back and looked at the day they walked in the door, what was their immunization rate? And it was 50%. Then we looked at 3 years later, Bayview Child Health Center patients consistently between 96 and 100%. Well, how the heck did we do that? We didn't do that by educating our clinicians, which actually was just me, about at the time, we got another clinician on in 2009. But we didn't do that by saying immunizations are important and let me tell you about tetanus and pertussis. We did it by chart reviews. Chart reviews that we did initially annually and moved to quarterly. And what happened was we would get to do the chart review. We'd say, and this was thanks to the Tipping Point community, which said, we'll give you money, but you got to measure this stuff, right? So we'd get to time for a chart review to report our outcomes. We'd pull all the charts and we'd say, what's our immunization rate? And my nurse would say to me, it's 78%. And I'd say, 78%? That ain't right. Pull me the charts of every kid who's due for an immunization who hasn't got it. And then for the next couple months, we'd bring all those kids in, and some of them wouldn't come. We'd call them, phone numbers changed, all this stuff, right? So we'd say, I'd say, okay, Bobby, Jimmy, and Susie, they all need their immunizations, but they haven't come in. Then Bobby would come in for a sore throat, and I'd say, Bobby, I got your name on a list. Here's your whatever you need for your sore throat, and here's your immunization that you missed. And that's how we kept it consistently between 96 and 100%. The way that we are going to move that bell curve to get all of our physicians doing this universal screening, and the way that we're going to get do ACEs-informed care, is we need to do chart review. We need to do chart review and say what percentage of your patients have received an ACEs screen. And for those kids who haven't received an ACEs screen, bring them in. get it done, or at their next visit, or they come in for something, and we're going to make time to make sure that that is done. If we don't do CQI, continual quality improvement, around ACEs screening and ACEs informed care, we're just talking about it. So how do we put this to use clinically, right? One of the really important things that when you start to do universal screening for ACEs, if you have a population that has a high prevalence of ACEs, what you're going to buck up against is, and probably many people deal with this already, is burnout, secondary vicarious trauma, and all of the issues of dealing with this. So we have to implement a trauma-informed system of care. That means recognition of the impact of ACEs and trauma on your patients, on your staff, and on yourself. So when I talk about this, and I put in the slide, you have to put your own oxygen mask on. So you have to create a system in which you and your staff are able to create space for the stuff that you're dealing with. And I say oxygen mask, but really, it's also, I'll say like an N95 mask. It's also like a clinical mask, because we know that HPA activation is transmitted from person to person. When I have someone who's up in my face, and that mom or that grandma or that caregiver is telling me about myself or telling me about the kid, that activates my fight or flight response, right? So when earlier today we heard from Dr. Ginsburg and how we're able to create sustainability for ourselves, where we get to that place where we can take a deep breath and that we can counsel our staff of what to anticipate, what the impacts are on the staff, so that we can continue to do this work is really important. Creating a system and a plan and taking a long-term view, understanding that exposure to ACEs and trauma and toxic stress is a chronic, relapsing, and remitting condition. We have families, and they will go in and out of crisis, and they will do really well for a while, and sometimes they'll fall off for a while, and that's what we expect. When we see a kid and they've got diabetes, we don't prescribe them an insulin regimen and be like, good luck to you, and I've done my job, you've got your insulin regimen, and you're done. You bring them back. You check in with them. Is it working? Is it not? And guess what? If that hemoglobin A1C is 11 or 15, as the case of one of my kids, Lord have mercy, right? We redouble our efforts. We don't blame the patient, right? And we don't say that insulin doesn't work. We figure out what's not working in this situation. Who is the caregiver? What's going on? How do we need to deliver it? Do we need to have a school nurse give the insulin? What needs to happen? When we think about how we put this to use clinically, we understand that what we're trying to do, we heard from Andy Garner earlier about positive stress, tolerable and stress, and toxic stress. We are trying to move the needle and hit on that green arrow to increase all of the factors that will push things from toxic stress to tolerable stress, which is the place at which the organism can recover, right? So what are our intervention targets? Well, they're those self-same things: neurologic, HPA axis regulation, VTA and reward center regulation, the hippocampus, neurotransmitters. All of those things are what we're trying to target clinically. So when we look at clinical data, I'm just like, what regulates the HPA axis? When we look at the inflammatory dysregulation, I'm like, what regulates the immune system? And in addition, for the endocrine system, what regulates all of these things? That's what I'm trying to get at. So right now, we have the tools. I will say that. I won't say we do a good job, because we're way behind. But we have the tools for primary and secondary prevention. We know that social and emotional buffering makes a big difference. We know that positive parenting, having a trusted mentor, healthy attachment, and social emotional skills, all of these things affect brain architecture, right? We heard that earlier today from or yesterday morning, from Andy Garner. So that is one of the targets for the neurologic, as I'm thinking about this in a systems wide. So many folks are familiar with my work through the writing of Paul Tuff with the New Yorker article, The Poverty Clinic, and then also his new book, How Children Succeed. And in both of those writings, he talks about the work of Michael Meaney at the University of British Columbia in Canada. And essentially what Meaney says is that he talks about the rat moms who licked their pups, and that those pups that had moms that did lots of licking and grooming when the rat pups were stressed out, that when they looked at those rat brains, that the pups who had high licking and grooming moms actually had the parts of their DNA that regulates for adult stress tolerance turned on, right? So that type of translational research that goes all the way from basic science to understand which interventions are going to be more effective clinically is so critical. And of course, we know that we have to lick our pups. So we do a good job. So we have the tools, I will say, for primary and secondary prevention. And as we're looking at targets for intervention, we look at things like exercise, which regulate heart rate and blood pressure, regulate the hypothalamic pituitary adrenal axis, decrease depression and anxiety, regulate cerebral neurotransmitters, including dopamine and serotonin, release endorphin, and also create the opportunity for healthy adult relationships. Oftentimes what we see with kids who have high ACEs score is that frequently there's an impaired parent. And so particularly exercise, and especially I will say in low-income communities of color, where there's a wide community of acceptance generally for exercise, that is one key part of our intervention. Another intervention is mindfulness-based awareness, which again targets heart rate and blood pressure, regulates inflammatory mediators, including C-reactive protein, regulates the hypothalamic pituitary adrenal axis, including and also serum cortisol, decreases depression and anxiety, and decreases in post-traumatic symptoms. Biofeedback, which helps to regulate the autonomic nervous system. And it's a real interesting thing when we're thinking about the progression to heart disease, right? The combination between the inflammatory effect and the increased sympathetic tone is something that we have to think about as a mechanism. So that's specific why we look at biofeedback as an intervention to help regulate the autonomic nervous system. And in addition, psychiatry and psychotherapy. These are all part of our clinical model at the Center for Youth Wellness, and this is how we use evidence to design a clinical intervention that is targeted at all of the ways in which adverse childhood experiences and toxic stress affect health, both in the short term and in the long term. But here's a question. What do tertiary and quaternary care look like for toxic stress and ACEs? So as a pediatrician, I did my residency training at Stanford, and I remember spending lots and lots and lots of time in the neonatal intensive care unit and in our pediatric intensive care unit. And for those who have not done pediatric training, if you have a baby that's born, right? The baby's born. If they're healthy, they go to the well baby ward. If they've got something going on with them, they'll either go to the intermediate care nursery or they'll go to the neonatal intensive care unit. And at Stanford, we have a quaternary care center. So for those kids who are really, really, really sick, who are doing really poorly in the neonatal intensive care unit, we have this thing called ECMO. It's extracorporeal membrane oxygenation. Is essentially a heart-lung bypass machine that allows you to be able to keep a kid alive long enough to do all of your interventions. And it costs a ton of money, but it's amazing and it's life-saving. I talked about the primary and secondary interventions that we are more or less able to do for ACEs and toxic stress. But what does the tertiary and quaternary care look like? Right now, sadly, tertiary care looks like this, essentially a group home. And quaternary care looks like this. That's unacceptable. It is unacceptable that we as clinicians do not put the resources, the research, the basic science, the policy behind making sure that this is not our quaternary care center. At the Center for Youth Wellness, our goal is to prevent by raising national awareness among those who have the power to make the difference. And that includes practitioners, policymakers, and parents. We screen all children at our center and teach others how to screen. And we heal by developing best practice, by bringing best practice, mental health, holistic wellness, mindfulness, nutrition, and movement integrated within our primary care center. Thank you.